Good morning and welcome to the AJOTEL Symposium. This is the corneal session and I will be discussing today the clinical factors associated with long-term stability after intracorneal ring segments implantation for keratoconus treatment. What variables can affect the long-term stability of intracorneal ring segments implantation? After we obtain a clinical regression of the disease, achieving an improvement of visual acuity, topography, and high-order aberration parameters, there are some factors that influence the long-term stability, and these factors are increasingly important as the patient is younger. The following are the factors that we think are involving long-term stability. 1. The medical treatment of the disease and its comorbidities, mainly the allergies. A correct indication of the procedure according to the evolutive stage of the disease. A correct selection of the implant characteristics, a precise surgical technique, and the biocompatibility of the PMMA implant. Keratoconus is a corneal ectatic disease strongly associated with systemic allergic diseases. It has been observed that ocular allergy and prolonged eye rubbing are strong predictors of disease progression. So the first treatment of keratoconus is a medical treatment, topical and systemic treatment of the allergic diseases, and preventive measures to avoid eye rubbing. This is crucial to avoid disease progression in virgin eyes and to prevent late disease progression after cross-linking or intracorneal ring segments implantation. A very important factor to consider is a proper disease classification. First, correctly classify the disease stage to avoid indicating an intracorneal segment implantation in a very advanced disease, with low pachymetry or a scar in the visual apex. Second, we need to classify the phenotype of the disease, the morphological characteristics and features of the ectatic disease, to choose the most appropriate segment to implant. And at last, a precise and predictable surgical technique to obtain a good centration and tunnel depth for the ring segment to be safely implanted. In the evolutive stage classification of Amsler, with 4 grades, we know that grades 1 and 2 are the most suitable for less invasive corneal surgeries, like isolated cross-linking or combined with corneal reshaping techniques, or another alternative with intracorneal ring segment implantation to reshape the cornea without removing tissue or affecting the central visual axis. Recently, in the last 5 years, we have been able to expand the indication of intracorneal ring segments to more advanced cases, with higher mean keratometry and higher corneal sphericities, by using a new model of segment, which is the long arc segment, with 300 or more degrees of arc length. In the presence of an Amsler grade 4 disease with apical scars or very steep curvatures, above a mean K of 55, the only indication would be a deep anterior lamellar keratoplasty. The morphologic classification, developed by Professor José Alfonso from Oviedo, Spain, was designed to improve the accuracy and predictability of intracorneal ring implantation. By using standard information available in any corneal topography, we can describe the phenotype of the disease in 5 main phenotypes, 2 central and 3 paracentral. Each phenotype indicates a specific feature of the ring segment to implant and a different optical zone to use. The variables to analyze to describe the disease phenotype and to choose the implant characteristics are the location of the ectasia, which is the location of the corneal thinnest point, the corneal asphericity value, the relationship between the topographic astigmatism and the coma high-order aberration axis, the amount of topographic astigmatism, and the minimum corneal thickness in the respective optical zone of implantation. In a paper published in 2021, analyzing the reasons for intrastromal corneal ring segment explantation, we can confirm the importance of correctly classifying the disease in terms of its evolutive stage and its morphologic phenotype. First, when the reason for explantation was a refractive failure, this happened mainly in patients with disease grade 1 or 2, meaning that surgery was well indicated, but the implant characteristics were incorrect for the type of ectasia to treat. When the reason for explantation was an indication for keratoplasty, this occurred in almost 90% of cases in eyes with very advanced disease, meaning that the problem was a preoperative incorrect indication for the procedure of ring segments implantation. Another very important factor to obtain long-term stability is to perform a precise and predictable surgical procedure to obtain a proper deep stromal tunnel and a good centration of the implant. We have published in 2018 a study describing the differences between the intended and the achieved tunnel depth of surgery. The difference between the manual surgery and the femtosecond laser-assisted surgery predictability was remarkable. This study was performed with high-resolution corneal OCT, measuring 3 different tunnel locations: proximal, middle, and distal location. Of course, that following the previous study, we were able to demonstrate in a paper published in 2019 that the postoperative complication rate was significantly higher in the manual surgery group, 18%, versus the femtosecond laser group, only 3.6%. In this study, we also demonstrated that the complications with manual surgery are more frequent in the first years of experience of the surgeon, during the surgeon's learning curve. And finally, the improvement of best corrected visual acuity was also significantly better in the femtosecond laser group of patients. In this slide, we can observe 2 examples of intraoperative surgical complications. On the left, a very deep corneal tunnel with decimate membrane detachment and corneal edema. On the right picture, an example of a posterior stromal tunnel perforation with the migration of the ring segment into the anterior chamber. More recently, 2 years ago, we published a study describing and confirming that the higher variability in terms of the tunnel depth achieved after manual surgery implies a higher variability in terms of astigmatism correction, with a higher incidence of cases with under and over correction. A more precise surgery leads to a more predictable results. The last clinical factor to discuss is the implant material used, in this case the PMMA material, which has been in use for corneal implants and intracorneal IOLs for more than 4 decades in ophthalmology. Previous confocal and scanning electron microscopy studies have confirmed that the PMMA material inside the corneal stroma is completely inert, does not induce any inflammatory reaction, and does not change the corneal nerve plexus anatomy. In order to respect the corneal collagen fibers distribution and the corneal nerve plexus, we must not use implants which are thicker than half of the total corneal thickness in the optical zone of implantation. Many complications regarding this were observed in the past when intact implants were used were very thick, sometimes more than 400 microns. This exaggerated stress in the collagen fiber structure and the corneal nerves induced an inflammatory reaction with protein deposits and corneal neovascularization that could lead to stromal thinning, stromal melting, and late implant spontaneous extrusion. The implants we are using today are thinner, are triangular, are completely inert inside the corneal stroma, do not induce inflammatory deposits or corneal neovascularization. The fact that we can achieve a predictable posterior depth of 70 to 80% of the total corneal thickness means that the implant corneal segment will be implanted in the deep stroma, avoiding damaging the main corneal nerve plexus in the anterior and mid-corneal stroma. This is very important because it avoids damaging the neurotrophic homeostasis of the corneal collagen fibers, and this is a factor that maintains the collagen fibers nutrition, avoiding possible inflammatory reactions and corneal melting. A recent study evaluated the corneal biomechanical changes after ring implantation. The authors observed a significant stiffening of the corneal response after surgery, and this may be due to a new stress redistribution caused by the new artificial limbus, leading to a possible interruption of the cycle of progressive focal weakening characteristic of the disease. Recent studies with corneal elastography were able to confirm that after ring segments implantation, we obtain a reduction of the collagen tissue strain. We could speculate that this change induces a lower nerve fiber strain stimulation, lower inflammatory triggers, and lower concentration of enzymatic collagen degradation proteins. Our investigation groups from Portugal and Spain have presented and published several studies demonstrating the long-term stability of intracorneal ring segments procedure, with studies with follow-up ranging from 5 to 10 years. In a very recent study from this year, we analyzed a cohort of pediatric patients with more than 5 years of follow-up. The success rate of the procedure was around 85% with manual surgery. A similar study, performed at the Fernández Vega Institute in Spain, obtained similar outcomes at 5, 7, and 10 years of follow-up, with a success rate above 90%. This cohort of patients has been treated with femtosecond laser-assisted surgery. In conclusion, intracorneal ring segments implantation is an effective and safe procedure for visual rehabilitation in pediatric and adult patients with keratoconus. The implantation reshapes the corneal morphology and improves the visual acuity. It induces a short-term stable disease regression, and the long-term stability is obtained in most cases, including young pediatric patients. Long-term stability depends on the medical treatment of allergy and eye rubbing, on a correct surgical indication and nomogram application, a precise morphological classification for proper implant, a safe surgical technique respecting the anatomy and the physiology of corneal nerves and collagen fibers. Thank you for your very nice attention.